Good morning, everyone. My name is Dr. Maha Guimei. I'm an assistant professor of pathology here at the College of Medicine, and I will be teaching you the hepatobiliary pathology. I'm going to be talking about the diseases of the liver and the hepatobiliary tree. So these are the objectives that you need to fulfill, and what I need you to know, and I don't care where you study from as long as you fulfill these objectives. So the question is always going to come related from these objectives, nothing from outside of that, not necessarily from all is present inside the lecture. So you need to look at the books and read the books. Before I start talking about the liver pathology, I want to introduce you to some terminology, some new terminology that we use in the liver that you need to be familiar with in order to understand the topics that we are going to be discussing in the coming two lectures. First of all, I'd like to introduce you to the anatomy of the liver and to the histology of the liver. As you can see here, the liver has two, on this surface, you can see two lobes, left and right lobes. And you can see that the external surface of the liver is very, very smooth. So if you close your eyes and put your hands on the liver, you can easily say it has a smooth contour, it has a smooth outer surface. You don't see any bumpy surface. On the histology level, we need to understand a few terms. The unit for liver function is called the liver lobule, a lobular model, a lobule. This lobule, as previously explained to you in the histology, has an hexagonal shape, and in the center of that lobule we have a vein. This vein is called the central vein. And what is the central vein? It's a tributary of the hepatic vein. So all the central veins come together at the end from all the lobules, and they form the hepatic vein, the right-left hepatic vein, common hepatic vein that goes straight into the inferior vena cava. So that's how the flow goes. So this central vein is a draining vein that drains the blood of the lobule, and it goes to the main hepatic vein, and from there to the inferior vena cava, and from there to the heart. At the periphery of the lobule, you see the structure here at the periphery of at all the peripheries of the lobule, you have several of these structures that we call portal tracts. These portal tracts are a bundle of structures, like the wires of the electricity in the wall. They have a bundle and many wires inside, and this bundle contains three important structures: a branch from the portal vein, a branch from the hepatic artery, and some bile ducts and ductules. Okay, so three structures. How does the blood flow in the liver? The blood flows, if you look at the histology here, let's apply what we just said on the real histopathology H&E picture here. You can see here in the corner of the slide, this is the central vein. So I'm going to just take one area, one acinus, which is one area of the liver, and look at. So you can see the central vein here. This is the acinus. In the corner here, you can see the central vein. And around the central vein, the hepatocytes, they arrange in rows. They arranged in rows, and these are single rows, like rows of the students, like they arrange like the sun. We usually describe them as the sun, and these are radiating rays of the sun. So the central vein is the sun, and the hepatocytes arranged in rows around it are the radiating rays of the sun. Okay, so these rays, these hepatocytes, they arranged in rows, and they come here close to the structure that on the corner that is the portal tract. This portal tract has a hepatic vein, has an artery, and has these bile ductules. Okay, and the blood flows. This has the blood supply. This has the portal vein, the hepatic artery. So the blood supply of the liver comes from these structures. The blood flows from the portal vein into the sinusoids, which are the pink areas between the rows of hepatocytes. It flows like that to be drained at the end by the central vein, and from the central vein to the hepatic vein, as we said, to the inferior vena cava. So the blood flows in this direction, from the portal vein to the central vein. from the portal tract to the central vein. So the area that is closest to the portal tract has the best blood supply, has the most rich blood supply and oxygen supply, and the area that is closest to the central vein are the more at risk area for ischemia, because it is the furthest away from the oxygen supply and the blood supply. Okay, so these are zones. Zone 1 is the closest to the blood supply. Zone 3 is the farthest to the blood supply. Okay, and that's the direction of flow of blood, and that's shown here in this diagram. You can see this is the central vein, okay, and that's the portal tract on that side, and you can see the blood flowing from the portal tract, and you can see these are the rows of hepatocytes. You can see them here. In between each row and the next one, there is blood. The blood is flowing in these sinusoids, blood sinusoids. So actually the liver cells are swimming in blood from both directions. They have blood on that side and blood on that side. They are soaked in blood. And this is important for them to be able to perform their functions. Another important base before we discuss the liver pathology is the segments of the liver. In anatomy, they previously discussed the segments, the liver as right liver, right lobe, left lobe, caudate, quadrate. However, these divisions, they have no actual role in surgery. The most important segmentation or segments of the liver for the surgery is another classification or another segmentation, where we divide the liver into 8 segments. Each segment has its own arterial supply, its own venous drainage, and its own biliary drainage. And this is important for us when we do the surgery, the surgeons do the surgery. They resect a lobe, they resect a segment. It has to be taken out with all its blood supply, so it will not affect the blood supply of other segments. So you need to understand that the liver has 8 segments. So if you look at it from the front, you can only see 2, 3, and 4. The 1 is at the back. The 1 is actually the caudate lobe that we call for anatomy the caudate lobe. You can see 1, 2, and 3 also from the back. And this is called the left part of the liver, 2, 3, and 4. This is not the left lobe, because the left lobe is only 2 and 3. The anatomical left lobe is only 2 and 3. But the left part of the liver, or the segments on the left side, are 2, 3, and 4. The segments on the right side are 5, 6, 7, and 8. So these are segments, and this division is very, very important of these 8 segments, because it is based on their arterial supply, their venous drainage, and their biliary drainage. So when you resect one segment, you do not compromise the blood supply of another segment. Another important thing to discuss before we discuss the pathology of the liver is the evaluation of the liver function. How do we evaluate if the liver is working or not? We use different measures to evaluate whether the liver cells are working and performing their functions or they are not. One is how to test for we have many cells in the liver, and we need to know if they are all working. If there is a problem with the hepatocytes, with the hepatocytic element in the liver, if the hepatocytes have a problem, have a disease like hepatitis, for example, then we have some enzymes that come out of these hepatocytes in the blood, and we see them in the blood high in the serum. So the serum AST, ALT, and LDH, all of these are enzymes that are present normally in the hepatocytes, and when the hepatocytes, they are necrotic and the integrity is compromised, we see these enzymes in the blood. They are become elevated. We see thousands of these ASTs and ALTs in the serum in cases of hepatitis with death and inflammation of the liver cells. We also have the biliary epithelial cells, that line the bile canaliculi. If these are compromised, if there's a problem in the liver biliary excretory functions of the liver, if there's problem in the biliary tree, we see increased serum bilirubin, whether conjugated or unconjugated bilirubin. This is another story to discuss. Or the enzymes of the biliary epithelium, they got high, which are the serum alkaline phosphatase or the serum gamma glutamyl peptidase. So these two enzymes, they appear in the blood. We test them in the serum, and they are high in cases of biliary diseases, if there is a disease of the biliary epithelium. The third thing that we do to measure the liver function is the synthetic function of the liver. The liver cells, they normally synthesized some proteins and factors like the serum albumin. So if the serum albumin is low, then the liver cells are not performing their functions. So the serum albumin is a measure for the liver synthetic function. The coagulation factors, we know that the liver cells synthesize the coagulation factors 2, 7, 9, and 10. So if all of these are not there, or the level of these factors are low, then the liver is not synthesizing. And how do we test for the level of the coagulation factor? By the prothrombin time and the partial thromboplastin time. And these are tests, I'm sure you've talked about them before when we talked about hematology and other coagulation problems. The other thing is the serum ammonia, the aminopyridine breath test to test for the the function of the hepatocytes. I've included this slide, although this is not time where we should be discussing jaundice, but I've just included this slide for your some extra information, just to remind you that the liver is a very important site for the formation of the bile. Actually, I'm not going to explain the slide because it's a little bit out of context and it will take a lot of time. However, I've put it just a summary for your jaundice. Jaundice is a very, very important manifestation of liver disease. It can happen in different forms of liver disease, whether this disease is an infection like hepatitis, it will show with jaundice, whether this disease is a biliary tract disease like cancer head pancreas, stones in the gallbladder, it will also appear as jaundice, but another form of jaundice, or if it's a hemolytic anemia and or physiological jaundice, which will appear in the different form again of jaundice. It is very, very important for you to understand the differences between the different types of jaundice, whether unconjugated, mixed, or conjugated hyperbilirubinemia. This table gives you all the differences in serum, in urine, in stools, and liver function tests, and the common causes only. I've included here the common causes for the different types of jaundice. Again, it will take a lot of time to go through all of that, but I've just added it for your knowledge and for your basic knowledge about liver disease. One important thing to say about liver cells is that liver cells are considered stable cells. What do I mean? There are three types of cells in the body: labile cells, which are the cells that constantly regenerate. So every day we lose skin cells and we have new cells being formed. The cells lining the GI, the gut, they regenerate every 3 days. We lose the cells and we have new cells being formed by the stem cells in the crypts of the GI. So these are called labile cells. There is a type of cell called permanent cell that we know we cannot change, we cannot renew, like the cardiomyocytes, like the brain cells, the neurons. These are permanent cells. We cannot renew these cells. But what are the liver cells? It's something in between. We call them stable cells. And these stable cells can only regenerate if they don't regenerate every day like the gut cells, but they only regenerate if they are injured. And that's a very, very important base for what we call liver donor transplantation, meaning that if we take away half of the liver or a third of the liver of a person, of a healthy person, that liver, under the effect of that form of injury that we've taken away half of its components, will regrow back to the normal size. And based on the fact that these are stable cells, and based on the fact that the liver can regrow back to its normal size, this is the basis of what we call today living donor transplantation becoming possible. So a liver transplantation from a living donor. So we don't wait for the person to die in order to take his liver. No, we take a piece of a liver from a person who can give or donate one segment of his liver to another person who has liver failure or tumors or hepatocellular carcinoma. That's part of the treatment offered today to these unfortunate cancer patients. I'm just adding a picture here, just to an old Greek mythology story, just to remind you of that stable cells. The god punished a guy called Prometheus by having him attached to a stone and letting the eagle come every day and eat his liver. So the eagle would come every day, eat his liver, and go, and then the liver would grow back to normal size, and the eagle would come the next day again and eat another part of the liver, and the liver would grow back to the normal size. Just to remind you, this was a story in an old Greek mythology until Hercules came and rescued this Prometheus from the eagle and the god. Now we finished our introduction about the basic concepts about liver cells, the basic concepts about hepatocytes. Now we come to our lecture, which is the liver nodules or liver masses. The masses that can occur in the liver. When we see a mass in the liver, what could it be? What is our differential diagnosis? When we talk about masses in the liver, as in any other organ, we must first classify. We must classify the masses in our head into two broad categories. In any organ, not only in the liver, this classification should go to any organ. One is non-neoplastic masses, so masses that are not tumors. These are not tumors, non-neoplastic masses. And masses that are neoplastic, that are autonomous growth, that can grow alone. They do not require a growth factor for them to grow. This is called an autonomous growth, so neoplastic masses. So broadly speaking, any mass in the liver can be neoplastic and can be non-neoplastic. The non-neoplastic ones, as you can see, include several ones, like one, focal nodular hyperplasia, which is a disease we're going to be discussing in a minute. Regenerative nodules, and I'm not going to discuss that today. I'm going to leave it for next time when we discuss liver cirrhosis. We will discuss the regenerative nodules and stuff that we won't be discussing today, like the abscesses, liver abscess. It's like any other abscess in the body, like it could be an amoebic abscess or a pyemic abscess or other infectious process like the hydatid cyst. All of these can present with masses in the liver. The other category is the neoplastic lesions, neoplastic masses of the liver. And in the liver specifically, we talk about metastasis as an important neoplasms of the liver. So metastatic tumors are actually more common in the liver than primary tumors. So metastatic tumors, secondary tumors, are more common than primary tumors. And when we talk about primary tumors, again, we need to reclassify in our head benign and malignant. Okay? And under benign, we have epithelial tumors that occur from the epithelium, like the adenoma, and we have mesenchymal tumor that occur in the liver, like the hemangioma. Also, with the malignant, we reclassify malignant tumor from the epithelium, like the hepatocellular carcinoma, the cholangiocarcinoma, or non-epithelial or mesenchymal tumors like the angiosarcoma and lymphoma. Okay, so always classify before you list your differential diagnosis. Have them classified in your head. First non-neoplastic and then neoplastic. Differential diagnosis of any mass in the body. Non-neoplastic, neoplastic. Under non-neoplastic, it could be infectious or non-infectious, like here, infectious liver abscesses, hydatid, or non-infectious, like any other process. Here, it's focal nodular hyperplasia and regenerative nodules. And neoplastic, when we say neoplasm, it can be primary, it can be secondary. And under primary, it can be benign, it can be malignant. Okay? And under benign and malignant, it can be epithelial and non-epithelial. So always classify before listing your causes. We start by focal nodular hyperplasia. I'm going to talk very quickly about three important topics today: focal nodular hyperplasia and two important tumors. The word focal nodular hyperplasia, as we said, it's a non-neoplastic mass. So the patient will come presenting by a mass in the liver. Okay, and our main aim when we investigate that patient is going to be to know whether this is a neoplasm, this is a tumor, or it is not a tumor. Okay, so we need to know how to diagnose what is not a tumor to be able to recognize it. So what is the pathogenesis of focal nodular hyperplasia? We really don't know. It usually results from any altered blood flow in the liver that leads to some hyperplastic changes in the hepatocytes. It doesn't have a really well-known or pinpointed cause, it is commonly associated with abnormal blood flow and hyperplastic changes in the hepatocytes. Grossly, how does it look like? It looks like that. It is very well circumscribed, like that. It lacks a capsule. It doesn't have a capsule. We don't see a capsule, so it is not a tumor. It is not a benign tumor with a capsule. So it is well circumscribed but does not have a capsule, but it has something very, very characteristic. A central stellate scar, a scar in the middle. A scar from which radiates branches from that scar, or fingers, fibrous fingers from that scar. So there is 3 important things. It is well circumscribed, it is not capsulated, and it has a scar, a central stellate scar. Usually the size is 5 centimeters or less. Microscopically, you can see that scar. You can see a bundle of fibrous tissue in the middle, and these septa radiate from the central scar and divide the hepatic parenchyma into nodules. So you can see the scar here in the middle. This scar usually contains thick-walled arteries or blood vessels in that scar, and sometimes inflammation in that scar. And that scar from which septa arise, they divide the liver into nodules. I'm not saying here lobules. The lobule is the normal hepatic architecture, but there is a central scar of a fibrous tissue scar from which radiates fibrous tissue septa that divide the liver into several nodules. That's how it looks microscopically. How do we confirm our diagnosis? Sometimes in the recent with the recent advances of medicine, also histopathology has greatly advanced. We don't only depend on the H&E for our diagnosis, like everyone has told you before. We use something called immunohistochemistry in order to confirm our diagnosis and make sure this is the right diagnosis. In order to confirm that this is the right diagnosis, we use something called glutamine synthetase stain. It's an antibody against this glutamine synthetase, and it gives this characteristic. It stains with the brown color. So anything brown is positive for this glutamine synthetase. It gives this map-like appearance with glutamine synthetase. And this helps us to differentiate it with the hepatocellular adenoma and the hepatocellular carcinoma that we will discuss in a bit. Most cases are asymptomatic, and they come to clinical attention only during if they are identified on imaging. If we do an X-ray or an MRI and we find a mass, then we become investigating this mass, but it usually does not give symptoms on the patient. Again, so nodules, we discussed the non-neoplastic, we discussed the focal nodular hyperplasia. I'm not going to discuss the rest of them because the regenerative nodules we are going to be discussing in the next lecture. We will start the neoplasms here. I will start by the cavernous hemangioma of the liver. It is the most common benign tumor of the liver. A hemangioma is a benign tumor of the endothelial cells. Hemangiomas can happen anywhere in the body, can happen on the skin, can happen in the mucous membrane, can happen also inside the organs. And one of the common organs that have hemangiomas is the liver. And as you can see here, this is a section, this is a slice of the liver, and you can see a brownish red-blue nodule. It is again not capsulated. It does not have a capsule. It is a benign tumor, but it does not have a capsule. Hemangioma is a tumor, is a benign tumor of the blood vessels. Cavernous means big blood vessels. So on the microscopic slides, you see large, dilated, thin-walled blood vessels, vascular channels or vascular structure. All of the arrows are pointing at vascular structure, blood vessels. Large, dilated, large is cavernous, dilated blood vessels. It is clinically asymptomatic. The patients will not always present by symptoms. And again, it is identified radiologically, and we need to list our differential diagnoses and exclude them. Unfortunately, if we suspect that the lesion is a hemangioma, it is contraindicated to take a biopsy, to take a needle biopsy from that lesion, and it needs to be totally resected. The third tumor we have is the liver cell adenoma, which is the benign tumor of the liver cell. I'm going to go a little bit quickly here. This is how it looks like, and it is strongly associated with the use of oral contraceptive pills. It is a benign tumor of the liver cells, benign tumor of the hepatocytes. We call it adenoma. Okay, it is strongly associated with the use of oral contraceptive pills and anabolic steroids that people use for the gym for growing muscles. What we're going to talk about here in the adenoma is the genetic background. It's important to differentiate the adenoma based on the genetic. Here we use the genetic testing. We have to use to identify the genes involved in the adenoma in order to predict the likelihood of it transforming into a hepatocellular carcinoma. So the most important thing about adenomas that you need to know, it's a benign tumor. Second, it is highly associated with oral contraceptive pills. Third is the genetic background of this adenoma. We have 3 types of adenomas based on the genetic background. One that is associated with the hepatocyte nuclear factor 1. And these ones have minimal risk of hepatic transformation to hepatocellular carcinoma. The second one occurs on top of an inflammatory background. It's called an inflammatory hepatocellular adenoma. And this one is associated with activating mutation of interleukin 6, JAK-STAT signaling. And these ones are more common in women, in obese women, and commonly associated with metabolic syndrome. And the third one that is most important for the transformation is the one associated with the beta-catenin activating mutation. And this one carries a very high risk of transforming into a hepatocellular carcinoma. It is also associated with oral contraceptive pills. We do the stain with the beta-catenin, and we see the beta-catenin staining the nuclei here. It is positive staining for the beta-catenein. Here this lecture comes to an end. So I've given you a small introduction about the liver cells. We've discussed non-neoplastic lesions like focal nodular hyperplasia. We discussed 2 important tumors of the liver like the hemangioma and the liver cell adenoma. Here I conclude this lecture, and in the coming lecture we are going to be discussing liver cirrhosis. And in the lecture after, we are going to be discussing the malignant tumors of the liver like hepatocellular carcinoma, cholangiocarcinoma, and others. Thank you very much. I hope this was useful, and good luck to all.